Good evening, everyone, and welcome to our joint webinar with Yetenaweg and Ethiopian Society of Internal Medicine. So before proceeding to the webinar, I would like to say a few things about Yetenaweg. So I'm sure most of you have heard about Yetenaweg before. So Yetenaweg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. It had a humble beginnings, only consisting of 2 founding members, but has currently extended its reach by including more than 150 active volunteer members spanning across 5 different countries and several continents, and it's counting. So there are several engagements that Yetena has committed itself to, but really they can be seen into 4 aspects. They are health promotion, community engagement, mentorship and skill sharing, and medical education. So in terms of health promotion, it's mainly consisting of discussion and articles. It could be via the health of the general public, or it could be in the formulation or implementation of health policy. So in terms of community engagement, it has actively engaged in community outreach. It could be in blood drive or blood donation campaigns. It could be inclusivity trainings, in equity projects, and in several fundraising campaigns. And through its mentorship and skill sharing, it has provided direct mentorship regarding soft skill or career and professional development via webinars and one-to-one mentorship to several mentees since its inception. And one of its other engagement is via medical education. So it is either through the CME or through the research and QI project. So as you can see, this is part of the CME. I'll talk more about the CME later on. So these are several images showing Yetenaweg's volunteers engaging in several community activities and in inclusivity trainings, as well as blood donation campaign. There's also a picture in the middle showing our recent health and art exhibition that was held several months back. This is also another image showing our volunteers participating, and in the lower right corner is an image showing a donation campaign that was undertook by Yetenaweg. So Yetenaweg and Roha also have a health article writing competition, which is done in collaboration with IMSA. So this is currently the 3rd round of health article writing competition, is once again organized in collaboration with IMSA. So Roha Medical Campus through Roha Health Foundation will award travel grants to 2 health article writing competition winners. We'll see the winners in the next slides. So Yetena will also award pulse oximeters for the top 20 winners and litmus stethoscope the top 3 winners, and top 5 winners will also get internship opportunities at Roha Health and other partner institutions. So as you can see, this is the 2021 article writing competition on the left half of the screen. The 2022 article writing competition winner has also been announced, but it was done online. Unfortunately, we do not have a picture showing that, but you can follow us on our social media to stay up to date with this as well. We'll share the links later on. So Yetenaweg also has partnered with Roha to provide a research fellowship. So its main aim was to increase the versatility of the healthcare professionals in terms of applying scientific research to the healthcare practice, and to create a space where healthcare professionals can showcase their research endeavors and get inspired, and also foster recognition in the commercial and business world, and to encourage key stakeholders and business entities to invest in scientific research. So it started on March 14th. So it was done in collaboration with Addis Ababa University Medical Faculty, with Tukur Ambassa Hospital, mainly involving 3 departments: oncology, radiology, and internal medicine. So research grants were awarded for 4 winners. We'll come to the winners shortly. It was also done in collaboration with St. Paul Hospital Medical College. So mainly this opportunity was provided for interns who undertook a research project as part of partial fulfillment for the degree of Doctor of Medicine. So it has been already launched and is well underway. So this is an image showing the respective winners from the Tukur Ambassa Hospital. So there were 2 winners from internal medicine, a female winner from oncology and another male winner from radiology. So besides the monetary difference, they're also provided with several mentorship and training opportunities that will help them in their future career ventures. So coming to our CMEs, so CME, as you know, stands for Continued Medical Education. So it's freely accessible, and Yetenaweg partners with Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, Ethiopian Venerology Society, and in this case, Ethiopian Society of Internal Medicine, to provide continued training for healthcare professionals. So 30 CME webinars have been held so far. Our average webinar attendees vary between 150 to 200 healthcare professionals. So in 2023 alone, 40 webinars focusing on non-communicable disease, on current issues, on mental health, and on sexual and reproductive health rights are planned to be held, and they are well underway. So we invite renowned international speakers, clinicians that are experts in their respective fields. So you can access our previous CME sessions on our Yetenaweg YouTube channel. We provide the links shortly. So you can get updates about our upcoming webinars by joining our Yetenaweg Telegram channel that is made for health professionals, and also following our social media posts on Twitter, Facebook, LinkedIn, or Instagram, whichever you find convenient. So for the best experience in the webinar, you can send your questions to the Q&A or to the chat box once the webinar is completed. And at the end of the webinar, you'll have a chance to ask directly if you're able to raise your hand. So to get the CU certificates, attendees must be able to fulfill the following set of criteria. The first is you should attend the whole session virtually. So the minutes attended will be checked by the Zoom attendee reports. So you should be able to fill the Google form for personal details and attendance. The link will be provided after the end of the webinar. So in 50%, if you're able to score 50% and more on the post-webinar quiz, you'll be provided with 2 CU points and a certificate. And the certificate will take 1 or 2 weeks to be issued and delivered into your inboxes. So we ask that you wait patiently. Okay, so having said that, today is November 14th. It's World Diabetes Day. So the Ethiopian Society of Internal Medicine, in collaboration with Yetenaweg, has prepared this webinar regarding diabetes, as you have seen. So the theme for the World Diabetes Day from 2021 to extended to this year is Access to Diabetes Care. And its slogan for the 2023 campaign is Know Your Risk and Know Your Response. So 1 in 10 adults have worldwide have diabetes, and over 90% have type 2 diabetes. And close to half are not yet diagnosed. And in 2023, the campaign mainly focuses on the importance of knowing the risk of type 2 diabetes to help delay or to prevent the condition, while highlighting the impact of diabetes-related complications and also the importance of having access to the right information and care, mainly to ensure timely or adequate management and timely treatment. So these are several posters that were issued in commemoration of the day. You can find it at the official website. So mainly they are depicting the slogans, as you can see for yourselves. These are also other webinars, other posters depicting the main themes that are being advocated this year. So this is also another slide showing that. So having said that, I would like to ask Dr. Abel to say a few things, 1 or 2 things about Internal Society of Internal Medicine. So Dr. Abel, the floor is yours.
Okay, thank you so much. Good evening, everyone. I would like to say a few points about Ethiopian Society of Internal Medicine. Ethiopian Society of Internal Medicine was established 10 years back on December 25, 2005, Ethiopian calendar, with a mission of improving the quality of healthcare by fostering clinical excellence and medical professionalism in practice of internal medicine, and visioning to be a recognized leader in promoting quality healthcare, advocacy, education, and research in internal medicine and its subspecialties in Ethiopia and beyond. And as part of our regular activities to enhance the knowledge and skills of our members, we have collaborated with Yetenaweg to present you our today's webinar on management of type 2 diabetes mellitus from 2 expert speakers. And so far, we have more than 1,000 members as a professional society and more than 1,500 associate members, mainly composed of internal medicine residents, around 18 chamber offices and 10 years experience of being a professional society. And as part of our routine CPD activity, we provide regular monthly CPD sessions for our members, some of which are broadcasted as such in a virtual session, and some are in person. I hope you will benefit a lot from our today's webinar and learn about internal medicine. Thank you very much.
So thank you very much, Dr. Abel. You've all heard about the Ethiopian Society of Internal Medicine. So our guest speakers today are Dr. Helena Getnet and Dr. Theodros Abera. So before proceeding, I would like to say a few introductory remarks about our guest speakers. So Dr. Helena Getnet is a consultant internist in diabetes, endocrinology, and metabolism specialist. She obtained her degree of Doctor of Medicine from Jimma University and then went on to specialize in internal medicine at Black Lion Hospital, where she also undertook her fellowship training in diabetes, in endocrinology, and metabolism, all while adorned with several honors and recognitions. Dr. Helena has contributed to academia via several esteemed positions and leadership obligations, including serving as a lecturer and department head in various teaching hospitals and institutions. She also has several publications in esteemed journals and has actively engaged in the preparation of several booklets, training manuals, and treatment protocol guides. So Dr. Helena's passion for healthcare and knowledge sharing extends beyond her clinical practice. She is a founder and current executive member of the Ethiopian Society of Internal Medicine and the Society for Endocrinology and Metabolism of Ethiopia. She is also a founding member of Marahut Internal Medical Center, where she currently serves as the medical director while actively engaging in clinical activities. Our other guest speaker is Dr. Theodros Abera. So Dr. Theodros Abera boasts a rich and diverse educational journey, traversing multiple esteemed institutions and acquiring a multitude of degrees and certificates. So Dr. Theodros Abera is a physician and the professor of endocrinology and metabolism at Addis Ababa University. He received his medical degree from Hawassa University in 2011 and completed his residency as well as fellowship training in internal medicine and endocrinology at the Kor Ambassa Hospital. So he has several publications, including research papers, books, and training manuals. He has assumed several pivotal leadership roles, starting from his early training years. He's currently presiding as the head of endocrinology and the metabolism unit of Addis Ababa University, and is also serving as chairman of the General Assembly of Society of Endocrinology and Metabolism of Ethiopia. He is also known for actively participating in several health promotion initiatives. So having said that, I'm sure you've all been well introduced to our guest speakers. So we'll directly proceed with the webinar. So the floor is yours, Doctor.
Okay, good evening, everyone. And Dr. Tadai, thank you for your kind introduction. So, and also thank you for having us speak on this special day, World Diabetes Day. So the topic that I would be discussing regarding the change in the treatment paradigm in type 2 diabetes. So as you all know, type 2 diabetes is one of the major health problems worldwide, and type 2 diabetes is also the predominant form of diabetes globally. And according to the 2021 IDF data, you can see that over the past 2 decades, the prevalence of diabetes has more than tripled, and currently, as of 2021, the IDF report again tells us that close to 537 million people are living with diabetes. And what is alarming about this figure is that, as you can see, 4 in 5 people with diabetes are living in low and middle income countries like Ethiopia. And diabetes also is a cause of death in more than 6 million cases annually. So again, the IDF projects us that in 20 years' time, as of 2045, the prevalence of diabetes is almost going to double. It's going to become close to 800 million. The proportion of 2045, you again see an alarming data regarding African prevalence is going to increase by more than 100%. So this makes it a major public health concern for us. So the same is true for impaired fasting glucose or pre-diabetes in general. So around 300 million people worldwide have pre-diabetes, and again, this is going to increase markedly in 2045. Coming to the Ethiopian data. Systematic review shows ranging prevalence between 2 to 6.5%, but according to a survey that was done in 2015, the prevalence of diabetes nationwide was found to be 3.2%, and the prevalence of pre-diabetes was around 9%. So having that in mind, are the proposed therapeutic options for diabetes. So lifestyle, healthy behavior, weight management, and pharmacotherapy. So what I'm going to focus today would be highlights or current emphasis points that are given with regards to each of these therapeutic options. So starting with lifestyle and healthy behavior, diet is one core component of lifestyle management. So there have been several dietary recommendations proposed by many authorities for type 2 diabetes management. But what is relatively applicable and practically simple to patients is the plate method, which was initially prepared and endorsed by the American Diabetes Association. So what this plate method advises is that in all of the major meals daily, 50% of each meal should be composed of vegetables. The rest 50% would be divided. 1/3 would be composed of beans, and the rest 1/4 would be composed of carbohydrates. This should be accompanied with adequate fluid intake, non-caloric fluid intake. So that is the ADA recommendation as far as diet goes. So weight reduction has always been recommended by the different diabetic associations. So ADA has always recommended weight loss of at least 5% in all diabetic patients in order to confirm metabolic improvement. But what is currently being emphasized upon weight management, weigh to 15% or more can have disease-modifying effect, and it could even lead to diabetes remission. So there have been several definitions for diabetes remission so far, but what is currently agreed upon is having A1C below 6.5% for at least 3 months without any diabetic medications. So what were the evidences to suggest lifestyle management in weight loss in particular to be an integral part of type 2 diabetes comes from studies that were done as early as 2002. So the EPP trial, Diabetes Prevention Trial, was one of the important trials that was done in 2002. So in this trial, more than 3,000 people were enrolled. So these individuals had pre-diabetes, and this studied whether to see whether lifestyle treatment or metformin therapy in those patients who had diabetes could prevent the risk of development of diabetes. So what was found at the end of the study was that lifestyle management, which targeted body weight loss of at least 7%, could significantly reduce a risk of developing type 2 diabetes as compared to metformin treatment and placebo. So this study was important because it highlighted the point that lifestyle and weight loss are superior in preventing type 2 diabetes in those individuals who had pre-diabetes. So DIRECT was the other study that was, again, an important study. This study was unique because it tried to address whether lifestyle intervention could still benefit those individuals who already have established type 2 diabetes with an earlier duration of diabetes. So in this study, type 2 diabetic patients who had either overweight or obesity with a shorter duration of disease, that is less than 6 years, were included in this study, and they were getting medication for their diabetes, but those who were receiving insulin treatment were not included in this study. So the primary outcomes of this study was weight loss above 15 kg and remission of diabetes. So these two primary outcomes, and at the end of the study, in the intervention group, 24% of the participants could achieve more than 15 kg body weight loss. And again, in the intervention group, almost half of the participants, that is 45%, were able to achieve diabetes remission. So looking further into the intervention group, what we find is that chances of diabetes remission was directly proportional to the percentage body weight lost during the study. So as you can see, diabetes remission was achieved by 86% of the participants who had lost more than 15 kg of initial body weight. So remission was also possible in almost 1/3 of those participants who had achieved 5 to 10 kg weight loss. So what this study emphasizes upon is the fact that even in those patients who had established type 2 diabetes, were already receiving medication for diabetes, could achieve diabetes remission or improve their metabolic profile with intensive weight management. So then came the retune study. Again, this retune study is unique because it tried to address the type 2 diabetic patients who didn't have overweight or obesity. So it tried to answer whether weight loss intervention could benefit type 2 diabetic patients who didn't have obesity. So these non-obese type 2 diabetic patients were enrolled in this study. They were given a low-calorie diet, and what was found at the end of this study was that the participants lost almost 10% of their initial body weight. So this was accompanied by mean A1C at the end of the study that was 6.4%, which is less than 6.5%. And this was also accompanied by significant percentage of fat loss in the liver and pancreas. 70% of the participants had achieved diabetes remission, and it took to achieve this remission was as early as 8 weeks. So weight loss, even in the non-obese diabetic patients, metabolic benefits. So weight style interventions is an integral part of diabetes management, and in addition to diet and weight loss interventions, weight loss medications should be adjuvant to the type 2 diabetes medication. So ADA recommends at least 5% body weight loss for all diabetic patients, but for those who have BMI above 27 and who could not achieve weight loss with lifestyle interventions, ADA recommends the use of obesity medications. And after 3 months of use, if one could achieve at least 5% body weight loss with this obesity medications, then these medications would be continued. So what are the evidences for these weight loss medications? So one of the drugs that are approved for weight loss management on top of glycemic control is the GLP-1 agonist liraglutide. So the scaled diabetes trial was the one trial which showed that liraglutide, 2 doses of liraglutide, 1.8 and 3 milligram doses, could achieve significant weight loss in patients with diabetes, improvement in glycemic control. So this weight loss was accompanied by reduction in other metabolic risk factors like blood pressure improvement and improvement in lipid profile. So the other GLP-1 agonist, semaglutide, had a similar evidence. So the STEPS trials were a series of trials that were conducted using semaglutide, and STEP 2 trial in particular was conducted in those patients with type 2 diabetes, and similar to liraglutide, 2 doses of semaglutide were used. Doses had resulted in significant percentage body weight loss in patients with type 2 diabetes, and you can see clearly that the weight loss is dose dependent. That is, the higher dose of semaglutide had achieved a greater reduction in body weight loss, but in terms of glycemic control, the 2 doses, both the higher and the lower dose of semaglutide, had achieved a similar A1C reduction, and this finding is true for almost all of the GLP-1 molecules that have been approved so far. So the conclusion from the stage 2 trial is both doses of semaglutide were effective in achieving significant weight loss and an A1C reduction of at least 1.5% as compared to placebo. So tirzepatide is a newer molecule that is recently approved. So this is a unique molecule because it is a dual GLP and GIP receptor agonist, and it has a half-life of around 5 days. The SURPASS trials were a series of trials that were phase 3 clinical trials that were conducted to see the efficacy of tirzepatide, both in terms of glycemic control as a primary endpoint and weight loss as a secondary endpoint. So in this 5 series of studies, the SURPASS studies, tirzepatide was compared to placebo as well as other potent diabetes medications, including semaglutide, which is as we saw earlier, potent weight loss and diabetes medication, and the 2 insulin analogs, degludec and glargine. And what was found at the end of the study was that tirzepatide, as compared to both semaglutide and the insulin analogs as well as placebo, had significant reduction in hemoglobin A1C. So this was true for all 3 doses of tirzepatide. So you can see, interestingly enough, A1C less than 5.7 was achieved significantly more with all the 3 doses of tirzepatide as compared to the semaglutide, degludec, and glargine. So with regards to the secondary endpoint, that is weight loss, in all of the 5 SURPASS trials, the 3 doses of the tirzepatide had demonstrated significantly higher percentage body weight loss, even compared to semaglutide, which is the initial weight loss, potent weight loss medication was approved. So following these evidences, as of May 2022, FDA has approved tirzepatide or Zepbound by the trade name of Mounjaro to be used for diabetes treatment. So retatrutide is another GLP molecule in the pipeline. So this is again a unique molecule because it is a triple hormone receptor agonist, agonist to GIP, GLP, and glucagon receptor. And this molecule had undergone a phase 2 clinical trial, which was published in August 2023. And what was seen in this trial was that retatrutide had achieved significant weight loss in both smaller and higher doses, 4 and 8 milligram doses. And this molecule would have to undergo further clinical trials, which before possibly being approved for treatment. So then comes metabolic surgery. So if one fails to achieve significant or weight loss with lifestyle management or weight loss medications, then ADA recommends bariatric surgery as a treatment option for those diabetic patients who had BMI above 40 or BMI above 35 with other comorbidities. So what we previously understood about the effect of metabolic surgery, that it's having as more of a mechanical effect with gastric volume reduction and reducing early satiety, has gone beyond that. And currently we understand that bariatric surgery could actually result in improvement of metabolic profile by multiple mechanisms. We now understand that it can actually result in increment in GLP-1 secretion. It can change the gut microbiota, and the change in adipose tissue profile and inflammatory markers could all result in reduction in insulin resistance. So metabolic surgery has been integrated as another important component of lifestyle management in type 2 diabetes. So The final therapeutic component would be pharmacotherapy. You all know the beta cell centric model that was initially proposed by Theodros, as omniacetylate had been later on revised as egregious 11. So this model tries to address the core pathophysiologic defects in type 2 diabetes. So you can see beta cell dysfunction, reduction in incretin effect, alpha cell defect, insulin resistance at the level of the muscle tissue, adipose tissue, liver, and brain. Change in gut microbiota and immune dysregulation, resulting in insulin resistance, increased stomach motility, and increased renal glucose reabsorption are all incriminated pathophysiologic defects in type 2 diabetes. And most of these pathophysiologic defects have been tried to be addressed by the different available medical therapeutic options. So what is the challenge in the management of type 2 diabetes, and why is there a need to change the treatment paradigm? Is that with all the previously available diabetes medication, the fact was that mortality benefit could not be demonstrated in almost all of the trials that were conducted before. So the most important cause of mortality and morbidity in type 2 diabetes was cardiovascular disease and renal disease. So CVD accounts for 30% of patients with diabetes have established cardiovascular diseases, and cardiovascular diseases were the cause of death in almost half of diabetic patients. And the same is true for renal diseases. 40% of patients with diabetes have established CKD, and CKD is known to increase the risk of cardiovascular death by 3 to 4-fold. So the opportunity to address this issue came after the cardiovascular outcome trials were started to be conducted. So you all remember some of the medications that were used earlier on, like rosiglitazone, were implicated as causing adverse cardiovascular outcomes. So following this report, the FDA had mandated cardiovascular safety trials to be conducted before any new medications were approved for type 2 diabetes. So these cardiovascular outcome trials were initially conducted to assure cardiovascular safety, but interestingly, the trials had revealed that some of the newer molecules that were being produced had demonstrated a better clinical importance, and as was summarized by Theodros as by Brownwald, you can see these trials, like the ones that were conducted using SGLT2 inhibitors and GLP-1 receptor agonists, had shown significant benefit in terms of cardiovascular and renal endpoints. So with regards to atherosclerotic cardiovascular diseases, using SGLT molecules like empagliflozin, cana, dapagliflozin, and ertogliflozin, as well as the dual SGLT1 and SGLT2 molecules, sotagliflozin, the cardiovascular outcome trials had included patients with established cardiovascular disease in the case of EMPAREC and SCORE trials. And what these trials demonstrated was that almost all of the SGLT2 inhibitors had benefit in terms of reducing heart failure hospitalization and cardiovascular days in the case of empagliflozin. And empagliflozin was the only SGLT2 molecule which did not demonstrate clinically significant benefit in the composite outcome of cardiovascular death and hospitalization, while all the other SGLT molecules demonstrated clinical regards to the heart failure outcomes. DAPA heart failure, impaired reduced, impaired preserved, and soloist trials were conducted using the different SGLT molecules. And what was different in these heart failure trials from the previous trials was that non-diabetic patients were included in these trials. So as you can see, half of the participants in almost all of the trials did not have type 2 diabetes, and except the case of impaired preserved, in all of the studies, the participants included had heart failure with reduced ejection fraction. And what was found at the end of these studies was that these SGLT molecules demonstrated a significant, clinically significant benefits with regards to reduction in hospitalization of heart failure. So this was also true for those participants in the impaired preserved study who had a better systolic function. So the DAPA preserved study was later on published, and it showed similar clinical effect as to the IMPA preserved study. So you can see that in terms of the primary outcome, which is reduction in heart failure hospitalization, in DAPA demonstrated clinically significant benefit as compared to placebo, but this benefit did not translate into reduction in cardiovascular mortality. So coming to the renal outcomes, EMPA-REG trial using empagliflozin was the first trial which showed clinical benefit with regards to renal outcomes. So the composite of doubling of serum creatinine, increment in albuminuria, initiation of renal replacement therapy, and mortality due to kidney diseases, hazard ratio was significantly reduced in those participants who used empagliflozin. So similar benefits were seen in the impaired reduced and canvas trials. So canagliflozin and empagliflozin had demonstrated renal benefit as a secondary endpoint in these trials, but the Credence trial was the first clinical trial which was conducted and which used the renal endpoints as a primary endpoint. And in this trial, the participants had a reduced EGFR, and the primary endpoint was achieved, similar to the previous studies. Similar findings were also seen in the DECLARE-TIMI trial. This trial is again unique because it included type 2 diabetic patients who had a normal baseline EGFR. And this trial highlighted the fact that the effect of SGLT inhibitors and dapagliflozin in particular was similar in those patients who had relatively normal baseline renal status. So then came the DAPA-CKD trial. So in this trial, the participants included had a reduced EGFR at baseline. And what the trial demonstrated was that in those patients who already have established renal diseases, dapagliflozin still had a benefit in terms of the composite renal outcome. And the other important point from this study was that 1/3 of the participants in this study were non-diabetic, and it showed that the renal effects of dapagliflozin were similar in those with and without diabetes. So similar to the DAPA-CKD trial, the IMPA-KIDNey trial had enrolled participants with established renal diseases, and this trial was in fact discontinued early because of clear benefits that were seen with empagliflozin. So a meta-analysis of all the 4 mentioned trials, which included close to 40,000 patients, shows that as a class, SGLT2 inhibitors had significant reduction in the risk of progression of renal diseases as a composite outcome. So 2 points to emphasize with the renal effects. from this meta-analysis is that this renal benefit was irrespective of the baseline eGFR, and it was independent of the glycemic effect. And the second point, important point, is that the renal benefits were seen in those patients with and without type 2 diabetes. So what are the proposed mechanisms for this cardiovascular and renal benefits? So for cardiovascular mechanisms, the reduction in blood volume, reduction in weight, reduction in blood pressure, improvement in erythropoiesis, and delivery of ketone bodies, and improved energy utilization by the cardiac myocytes were all proposed mechanisms for the cardiovascular benefits, while the renal mechanism is mainly because SGLT2 inhibition results in increased delivery of sodium to the macular densa cells, which would activate the renal tubuloglomerular feedback, resulting in constriction of afferent arterioles and dilation of efferent arterioles, which eventually would result in reduction in intraglomerular pressure. So there were other clinical benefits that were noted in mentioned trials. These include reduction in atrial and ventricular arrhythmias by dapagliflozin, improvement in erythropoiesis, and improvement in anemia. And the other important outcome was reduction in risk of obstructive sleep apnea, which was noted with empagliflozin. So coming to the other important medications, the GLP-1 receptor agonists, we have GIP and GLP-1 receptor stimulating hormones, the incretins. You all know their mechanism of action. So what was their benefit beyond reduction in A1C was that in the clinical trials, which would grossly see later on, reduction in major adverse cardiovascular outcomes was noted in type 2 diabetes, in particular with dula, lira, sema, and semaglutide. And the other important clinical benefit of these medications was weight loss. So we have this GLP-1 receptor molecules. So we have lexisenatide and exenatide, which are short-acting molecules, and we have lira, sema, albi, and dulaglutide, which are longer-acting molecules. And semaglutide is the only available GLP-1 molecule which has an oral formulation. And what this cardiovascular outcome trials demonstrated was that the four longer-acting GLP-1 molecules, lira, sema, albiglutide, and dulaglutide, had shown significant reduction with regards to the cardiovascular endpoints. So here are the available GLP-1 receptor molecules, medications. We also have a fixed dose combination with insulin analogs. So we have the diglira, which is a combination of liraglutide and insulin degludec. We have glarlexi, we have a combination of lexisenatide and insulin glarg. So in terms of their benefit, in terms of A1C reduction, you can see range between 0.8 to 1.8%. Semaglutide is said to be the most potent in terms of reduction in A1C, and the same is true with regards to weight loss. So another important thing to note with the use of these molecules is that lira, sema, and dulaglutide need no dose adjustment with advanced kidney disease, while the other molecules would be contraindicated in a more advanced renal function. So the other new GLP molecule that has been recently added to the group would be ipeglinetide. So this is an exenidine-based GLP-1 receptor agonist. So the Amplitude O trial, which was published in 2021, demonstrated that this molecule could actually be a potent therapeutic option in terms of A1C reduction and weight management. So this drug awaits approval after further clinical trials. So what is the side effect of this GLP-1 receptor agonists? The most outlined side effect is GI upset, nausea and vomiting. Is reported with almost all GLP-1 receptor agonist molecules as a class. And what is recommended is slow initiation and titration scheme in order to avoid this GI intolerance. So having these all evidences in mind, what the European and American diabetic societies recommend currently as a consensus statement is that while managing type 2 diabetes, early risk stratification and individualization of treatment should be done initially before we choose therapeutic options. So while doing that, the most important questions to address would be whether an individual has any cardiorenal risk factor or any established cardiorenal diseases. So with this regard, if there is an established atherosclerotic cardiovascular disease, be it MI, stroke, peripheral arterial disease, carotid arterial disease, and so on, or whether there is a high risk for atherosclerotic cardiovascular disease, including those patients who are age above 55, who have other risk factors like smoking, hypertension, dyslipidemia, and albuminuria. The ADA and the European authorities recommend the use of GLP-1 receptor molecules with proven cardiovascular benefit. If that cannot be done, the other option would be the use of SGLT2 inhibitors. And if while stratification, if there is any heart failure, whether with systolic, preserved systolic function or systolic dysfunction, SGLT2 inhibitors who have proven clinical benefits should be considered in those individuals. If we are dealing with CKD, then SGLT2 inhibitors are again the preferred medications as far as the eGFR is above 20. So in those patients who don't have any cardiorenal risk factors, the next questions to address would be whether there is a need for weight loss management, or there is a need to address glycemic targets. So for weight loss, for those in whom we need to address weight loss as a primary therapeutic option, we would use the proposed medication that we saw earlier, who have demonstrated clinical efficacy in terms of weight loss. So tirzepatide and semaglutide has the highest clinical efficacy in terms of weight loss, followed by the other GLP-1 receptor agonists, and metformin and DPP-4 inhibitors are said to have a neutral effect on weight. If our intention is to achieve intense glycemic targets, then again we have those medications who have a very high potency, like dulaglutide, tirzepatide, semaglutide, the insulin analogs, and we have the other medications along the way. So what other things we need to address in addition to cardiovascular, renal risk factors, weight management, and so on, is obesity and weight-related complications. So NAFLD and NASH, non-alcoholic fatty liver disease, and non-alcoholic steatohepatitis and obstructive sleep apnea are also the other known cardiovascular risk factors, and we need to address these cardiovascular risk factors as well. And it is known that GLP-1 receptor agonists and pioglitazone, as well as metabolic surgery, an established benefit in reversing NASH and hepatic fibrosis. And with regards to its obstructive sleep apnea, the use of SGLT2 inhibitors would be advised in order to avoid adverse cardiovascular outcome. So what are the key points that have been highlighted in the recent guidelines? Is that lifestyle management and weight loss in both pre-diabetes and established early diabetes should be an integral part of diabetes management, and this should include intensive lifestyle modification, medications for weight loss, as well as metabolic surgery. And the other important point is individualization of type 2 diabetes treatment, taking into account cardiorenal risk factors and addressing of other comorbidities like NASH and obstructive sleep apnea as a cardiovascular risk factors. And the other important component of treatment should be early intensification of treatment with combination treatment, particularly for those who have an earlier duration of diabetes. So this would be the end of my talk, and before I conclude, I would like to remind everyone that November 14 was chosen as the World's Diabetes Day is because of this great man who had contributed to the development of insulin, who have won the Nobel Award before, and in particular Frederick Banting, who was a Canadian orthopedic surgeon who had worked intensively with his other colleagues in order to invent insulin. And November 14 was actually his birthday, and it was to remember his legacy that this day was dedicated. So with that, I finish my talk, and thank you.
Thank you very much, Dr. Helena, for that informative and engaging presentation. Dr. Theodros, please proceed.
Okay, so good evening, everyone. First of all, I would like to thank the Ethiopian Society of Internal Medicine and Yetena for organizing this CME on this particular day, World Diabetes Day. So the motto for the day was know your risk and know your response. So it directly indicates prevention. So Dr. Helena tries to address how type 2 diabetes is prevention in type 2 diabetes, and now I'll talk on prevention of complication. So one of the complications which commonly neglected is diabetic disorders. So with that, I'll proceed to my presentation. So this will be my outline of presentation. I will just talk on the magnitude, risk factors, and I will also talk on the prevention and treatment and intervention to enhance healing of food ulcer. So this already discussed. Now, diabetes is a true global pandemic. More than 500 million individuals are living with diabetes. That means 1 in 10 persons are already developed diabetes, and the terrifying figure is more than 50% of individuals already are not diagnosed, and 80% of those who have diabetes is living in low and middle income countries. So this is a very alarming figure, but if you look our data based on the IDF current estimates, the prevalence of diabetes in Ethiopia is reaching up to 5%. So with that, we need to think on prevention of type 2 and prevention of complication, because diabetes is the leading cause of blindness. It's a leading cause of end-stage renal disease. It's the most important cardiovascular risk factor and the most important cause of cardiovascular mortality. Apart from that, diabetes is the leading cause of non-traumatic lower extremity amputation. So we need to tackle and prevent complications of diabetes. So during my presentation, I will refer some terminologies, so it's important to define them. When I say diabetes food, it refers to the variety of pathological conditions that can affect the feet of diabetic patients. When we talk about foot ulcers, it's just the lesions involving a skin break with loss of epithelium, and that can extend to the dermis or deeper layers, and sometimes it involves the bone. And when you say amputation, it's just to mean the removal of the terminal non-viable limb of an individual. This is the current new terminology that is talked in diabetic foot world, so foot in remission. Now, once a patient develops foot ulcer, even though the foot ulcer healed, that is the most important risk for subsequent development of foot ulcer and amputation. With that, now the important terminology is we label patients once the foot ulcer is healed, we label them as foot in remission because the recurrence is very, very high. So how common is diabetic foot disorders? So diabetic foot ulcer is a significant concern worldwide. Every 20 seconds, somewhere in the globe, we lose one limb, and millions of people with diabetes suffer from poorly healing foot ulcer, which will affect the quality of life. Based on the IDF estimate, the current estimate, 14 to 60 million people globally are affected by diabetic foot ulcer, which is, the estimate is just half of this number in 2015. So within 5 to 8 years, it really doubled the number of patients affected by diabetic foot. So 1 million people globally undergo some forms of amputation, and this is a really, really a huge burden to the healthcare. So if you see as individually, the lifetime risk of person with diabetes developing foot ulcer estimates at around 34%. And the risk of amputation is also very high in patients with diabetes than the general population. When we talk about diabetic foot ulcer, we are also talking about mortality. The mortality of patients having amputation after 1 year can reach to 40%, and after 5 years, it can reach to 39 to 80%. So that is really an alarming figure. So the majority of foot amputation preceded by foot ulcers. Regarding local data, we do in Addis Ababa University, Dr. Ambessa Specialized Hospital, we had a diabetic foot clinic, a dedicated diabetic foot clinic, and we do some clinical audit for patients we treat for the past 2 years. Around 86 patients are included in this clinical audit. Majority of them are type 2 diabetic patients. And if you see the duration, patient can develop foot ulcer starting from the diagnosis from the first year up to 47 years, up to many years of the development of diabetes. So the most common risk factor in our patient scenario was peripheral arterial disease, accounts for 75%. The others are neuropathy in 50%, and 22% of patients have history of previous ulcer, which is somehow different from the global risks. If you have patients with diabetic foot ulcer, screen them for other complications. In our patients, 40% of them has established atherosclerotic cardiovascular disease, and 30 to 21% of patients have diabetic kidney disease and diabetic retinopathy during the derivation. So majority of patients had advanced ulcer, grade 3 and more, and 20% of patients already had osteomyelitis or involvement of the bone during the time of presentation. If you see the outcome, 64% of ulcers healed during the follow-up, 46% of patients undergo amputation, and around 3% of ulcers remained, and that will affect the burden, the healthcare cost, and it affects the quality of life of the patients. So in general, the risk factors for diabetic foot disease are 1, peripheral neuropathy, peripheral arterial disease, past history of foot ulcer and amputation. This is the most common risk factor. Other diabetic-related complications, retinopathy, pressure demonstrated by the presence of callus, the presence of blisters, which indicates shear or friction, and elevated foot pressure, whether from ill-fitting shoes or any other pressures, deformities, edema, and poor social background is one of the common risk factors for the development of diabetes. So if you see the pathogenesis, multiple risk factors come together. In diabetic patients, there is microvascular and macrovascular abnormalities, which can lead to ischemia. There is motor, sensory, autonomic neuropathy, which can affect or which can reduce the pain sensation. There will be formation of callus, formation of deformity because of the motor neuropathies, and also abnormal posture. And with the presence of infection and predisposition to infection and the precipitating or the eliciting trauma, patient can develop food ulceration. So multiple risk factors can happen in individual patients for the development of diabetic foot ulcer. So foot ulcer in general classified into neuropathic and ischemic, and sometimes there is the third one, neuroischemic. So neuropathic foot ulcers commonly seen in the plantar side of the foot, whereas the ischemic foot resides in the tip of the toenails. So looking on some of the risk factors, peripheral arterial disease in diabetic patients, it's common, usually diffuse, bilateral, and vasculature of the foot. So in physical examination, you can see trophic signs, loss of hair, thickened dysmorphic nails can be seen. And if a patient develops pure ischemic foot ulcer, usually these are painful ulcers. So if there is ulcer, if there is peripheral arterial disease, you need to grade them depending on the level of pain in which patient will experience during activity. So from symptomatic, mild claudication, moderate to severe, and once the patient develops ulcer, these are the most advanced peripheral arterial disease. And patient can present with clear-cut gangrenous changes, mottled skin, dysmorphic nails. These all are signs of peripheral arterial disease in individual patients. So we need to screen peripheral arterial disease, and the commonest things that we can do in our day-to-day clinics is just palpating the distal pulsations, and then we can also do ankle brachial index with the help of handheld Doppler. In some centers, we had these Doppler meshes, so we can check between the ankle and the brachial pressure. And if the ankle brachial index is less than 0.9, that indicates peripheral arterial disease. If that is less than 0.5 or 0.4, that indicates critical limb-threatening ischemia. But the caveat here in diabetic patient, it can be falsely elevated and reach more than 1.3 because of calcification. And this is common in diabetic patients and in patients on dialysis. So in such type of patients, in best setups, you can do two pressure measurements or transcutaneous oximetry, which can also help us in determining the ulcer healability in advanced foot care settings. If we suspect and clinically consider possibility of peripheral arterial disease, we need to undergo imaging. We can do Doppler ultrasonography, or we can do CT or MRI angiography, which can show us the degree of stenosis, calcifications, narrowing, occlusions, can be well visual referred to for vascular colleagues for intervention. Another common risk factor is neuropathy. So when you talk about peripheral neuropathy, it has three components: sensory, autonomic, and motor. So sensory neuropathy can be assessed by monofilament, which assess pressure. We can also assess position and vibration. When we talk about autonomic neuropathy, we can assess the skin for dryness. We can also look for distended veins and arteriovenous shunting, which can shunt the circulation with shunt the vascular supply from the arteries directly to venous system, leaving the capillary bed, which leads to ischemia. And in motor neuropathy, you can see loss of reflex with your hammer. You can also see loss of intrinsic muscles, and you can see atrophies, deformities, altered biomechanics can be seen. So sensory motor neuropathy developed in 40 to 50% of patients with diabetes after 10 years of diagnosis. But in our experience, majority of patients during presentation, because of long years of undiagnosed diabetes, they already had neuropathy, even at the time of the clinical diagnosis. The impact of neuropathy is might there is loss of protective sensation. Patients will have these neuropathic pains, having burning, stinging, shooting and stabbing like sensations, which can affect quality of life. It can impair their work productivity, and it can also limit their physical activity. And the commonest risk factors for neuropathy is poor glycemic control, followed by other metabolic parameters, poor lipid, PP control, diet and obesity contributes for the presence of neuropathy. Smoking and lack of exercise also contributes for the development of neuropathy in diabetic patients. So how to assess? At least we need to do 10-gram monofilament plus any one of the listed examinations. We can use pinprick sensation, we can use vibration testing with tuning fork, or we can quantitatively do vibration perception threshold, and we can also do the ankle reflex. So these are the tuning forks. The bottom, this is the machines that we do BPT, which can quantify vibration sensation in our patient. This one, the upper one, is how to do the monofilament test. The monofilament should buckle to say it is active, and we can do at least in 9 areas, 9 in the plantar side and 1 in the dorsal side, in total 10 sites. And if there are 4 negatives out of 10, we can say there is loss of monofilament sensation. And we can also do a revised version, 4 areas and 1 negative out of 4 monofilament. We can say it's a positive test. These are the different deformities that you can see. In the first image, you can see the hallux deformity with concomitant callus, overcrowding of the nails are seen. And if you see the tip of the nails, because of the neuropathy and loss of position, this patient traumatized the tip of the nails, and you can also see calluses. These calluses are thickened skin, and these are not a benign lesions. If you debride the callus, you can see the presence of ulcer in the lower, in the background of the callus. So if you have callus, you need to be careful, because these are pre-ulcerous lesions. In the lower bottom, you can see there is shattering and grooves in the plantar side because of loss of the intrinsic muscles. This is the claw foot, and there is a hammer foot deformities, which are clearly seen in those pictures. And this will create pressure in specific areas, and these areas are at risk for foot ulceration. The bottom right, there is a charcot foot. This is neuropathic deformity, where there will be loss of the arc of the foot, and you can see ulcerations at the bottom of the foot. So deformity is one of the most important risk factors for foot ulcer formation. And these are the different types of deformities. Flat foot, there will be claw foot and high arched foot, overcrowding in hammer and glaucos. You can see different areas of pressure, and head of metatarsals. These are also another side of pressure areas. The heels of the foot are also areas for pressure, and these are the common areas for food ulcerations in patients with diabetes. So whenever there is deformity, there will be excess pressure, and there will be formation of callus. Below the callus, there will be shear, and there will be separation of the layers of the skin. And when the callus break down, there will be clear-cut ulceration, and that will be an entry for infection and involvement to the bone. So how to assess pressure sites? In our foot clinic, we use the foot imprinter. This is what we call the Paris mat, which we can do static as well as dynamic pressure assessment. We ask the patients to work on this scanner, and as you can see in the paper, it will print the pressure site. So those areas which are darker areas are the high pressure sites, and these sites are high risk sites for foot ulcer development. So footwears are very important, and whenever you examine a patient, a diabetic patient, you need to examine their foot and look what type of foot they are wearing, and you need to advise them what is the proper footwear for this particular patients. So the most important thing is you need to advise them to have a larger toe box in their shoe, and the shoe should be adjustable. It needs the bump, and the collar should have some comfort, and the heel should be a little bit higher, but the patient should not wear very high heel shoes. And always they should buy their footwear late in the afternoon, where there will be much edema, and they need to increase one number from their previous footwear. So they should also use a good insert, which can also affect, or which can also distribute the pressure all over the foot rather than concentrated in one particular area. So diabetic education is very important. You need to educate your patients to wash their foot daily. They should try it, and they should look for any bumps. They should look fungal infections or any lesions between the toes. They need to cut their nails in straight manner. They shouldn't go in the sideways. They need to look at the bottom of the foot with the help of mirror. And if they see any dryness, cracked skin, they need to apply ointments, creams, or emollients, and they need to document anything they see, and they should discuss with their healthcare providers. And this should be given routinely to diabetic patients, so that we can prevent the development of foot ulcer. And once we examine our patient, we need to do a risk stratification. This is based on the International Working Group for Diabetes 2023 risk stratification. Those patients with no signs of peripheral arterial disease and no loss of protective sensations, at least you can do foot screening once a year. For those patients, either of them positive, you can do at least every 6 months. Those patients with loss of protective sensations plus peripheral arterial disease, or two risk factors, you need to see them 3 to 6 months. Those patients are thought to be having high risk, and those patients with loss of protective sensation or peripheral arterial disease, plus one of the following, that is history of foot ulcer or history of amputation, or those patients with end-stage renal disease. These are very high-risk patients, and they should be seen regularly, at least every 1 to 3 months for screening, prevention, modalities, and then if there is foot ulcer, we need to consider management. So the key elements in the prevention of foot ulcer is identify person at risk for foot ulceration, regularly inspect and examine the feet of patient at risk of foot ulcer, provide structured education for the patient, families, and even for the healthcare professionals. And we need to encourage routinely wear appropriate footwear, and we need to treat the risk factors, the peripheral arterial disease, the neuropathy early on before the development of ulceration. But once a patient develops ulceration, then we need to manage the foot ulcer. So the first thing that you need to do is classify that ulcer. So there are different classifications. The well-known classification is Wagner's classification. It's just a vertical classification. It grades the ulcer from the pre-ulcerated lesion, superficial deep involvement of the bone, localized gangrene, and full-blown gangrene. So this is just a vertical classification. But this is not the only things that affect the healing. But now the University of Texas and the Wi-Fi system comes to the picture. So they are better because they also involve the presence and absence of infection, the presence and absence of ischemia, which can affect the healability of the ulcer. So you can use this University of Texas, which is widely well validated and widely practiced nowadays. This is the Wi-Fi system, which is relatively better than the University of Texas because it defines infection thoroughly into mild, moderate, severe infections, and that can affect your decisions in selecting different types of antibiotics. And regarding the ischemia, it also you utilize the ankle brachial index, and based on that you can grade the level of peripheral arterial disease, and you can also follow your patients based on the different grades in the wound, in the infection and ischemia categories. So the management principles relies on 4 pillars. The first is we need to relieve the pressure and protect the ulcer bed. So we need to do offload that foot. So we can use total contact cast, or we can use different therapeutic footwear. So based on the current guideline, it's the type of offloading device that we can use depends on the area where the ulcer locates. So for non-plantar ulcers, you can use removable offloading devices. For plantar and midfoot ulcers, the first line is non-removable offloading device. If these are contraindicated or are not available, you can use removable offloading device, or you can use appropriately fitting footwear, which can be custom made. So in our clinic, we had those removable offloading devices. This is a removable device, and in the lower you can see custom-made offloading shoes, which can be given for different types of ulcer, to offload the different types of ulcers in our patients. The second pillar is restoration of the skin perfusion. So you need to address the cardiovascular risk. So you need to lower their cardiovascular risk with your statins, your aspirin, or antiplatelet agent. And sometimes you can also consider combination of antiplatelets with low-dose anticoagulants. They should be sent to vascular surgeons for perfusion. That can be done by stenting or plastic. Whatever the thing we need to address or restore the perfusion that affects ulcer healing. The other is treatment of infection. So it's really important to know when to act topically, as well as systemic antibiotics should be given. So the first thing is we need to consider superficial critical colonization, which needs topical antibiotic coverage if 3 of the 5 signs are present. So if the wound is not healing by at least defined by 30% reduction in 4 weeks, if there is increased exudation from the wound bed, if the wound bed is red, there is friable granulation tissue, there are necrotic debris, if there is a bad smell, at least 3 of these criteria are met, then there is superficial colonization. So this wound, at least the minimum, needs topical antibiotic coverage. Systemic antimicrobials are needed if 3 of the following factors are present: if the wound size is increasing, if there is increased peri-wound temperature. Now this is one of the area of interest in wound care professionals, because it can help us to assess the wound in the clinic, as well as we can also provide thermometers, especially those infrared thermometers, to the patient, and they can also track the peri-wound temperature. If you probe the bone and found the presence of osteomyelitis, new areas or satellite ulcerations are developed, the patient develops those. If there is edema or cellulitis, if still there is increased exudation, and if there is bad odor from the wound bed, then 3 of these present, then that needs systemic antibiotics, either oral or intravenous. So to differentiate between oral and intravenous, you need also to look for the derangement in the vital signs. So the role of infrared thermometers we are using prior to the COVID era for the wound care practice, and Professor Sibat already validate these infrared thermometers. Now in COVID, we are using them for screening of febrile patients, but still those infrared thermometers can be used to assess a wound. If there is deep and surrounding infection, you can at least identify, if you compare with the contralateral side of the foot, if there is greater than 2 degrees Fahrenheit difference, that indicates deep and surrounding infection. If there is charcot, then there will be a difference of more than 4 degrees Fahrenheit between the 2 limbs. So it can be used to track infections. It can help the patients to track and seek medical attention once you send them home. The presence of osteomyelitis can be done with looking the size of the ulcer, if the hematologic parameters, WBC, erythrocytes, C-reactive proteins, and if you probe to the bone, and if you repeat the plain films or plain X-rays after 2 weeks, you can also diagnose osteomyelitis. Early on, MR or CT can help to diagnose osteomyelitis in particular patients. So depending on the different severity of infections, you can choose the different antibiotics, but always you need to have a practice of taking culture. So these are the startup empiric antibiotics for our patients, but once the culture result is available, we can shift to culture-based treatment. So apart from the treatment, then the local wound care is very important. So there are 3 components on the local wound care: debridement, inflammation and infection control, and moisture balance. We usually send our patients for routine wound care to health centers or clinics, but proper local wound care is very, very important. So wound bed preparation is very important for healability of the wound. So you need to look on patient and family center concerns. Sometimes a patient might not have access for local wound care. You need also identify and treat the possible cause for chronic wounds. So in patients with diabetes, glycemic control, lipid control, and so on are very important elements in the management of the local wound. And then you need to determine healability. So we can classify wounds based on healability into healable, non-healable, and maintenance wounds. Healable wounds are those wounds with adequate blood supply and no infection, which can be healed if you do routine wound care. So in those wounds, you need to do active in-depth debridement, moisture balance should be given, and you need to treat inflammation and infections thoroughly. For non-healable wounds, these are because of the associated illness, ischemia, and so on. These are non-healable wounds. So for them, active debridement is not recommended. That's what you can do is removal of the slabbed material from the wound bed. You can use antiseptics to reduce the bacterial burden, and at least you need to consider moisture reduction from the wound. Maintenance wounds are, these are wounds which can last for prolonged period because of patient or health care barriers, for example, unavailability of expertise or unavailability of some of the wound care gadgets. Some patients might have foot ulcer for prolonged period of time. These are maintenance wounds. At least here you can do in your local clinics conservative debridement, bacterial reduction, and moisture reductions can be done. You can use different antiseptic agents for different types of wound. So if you use chlorhexidine, which have low toxicity to the tissue, and if you use povidone iodine, which covers a broad spectrum of antimicrobials, and you can also use acetic acid, especially for Pseudomonas coverage. You can use those antiseptics. If you use hydrogen peroxide, which you commonly use, its action lasts only for just a few minutes until the fizzing of the fluid stops, and there is risk of air embolization. Saline or stellar water can be used, but it doesn't have any antibacterial benefits. So moisture balance is important. When there is excess moisture in the wound, it can affect the healing because it can break down the wound bed and the surrounding skin. If there is low moisture, which can lead to scar formation, necrosis, and which also affect epithelialization. So you need to balance the moisture in the wound. So in moist wounds, you need to do compressing. So you can apply your antiseptic, but you need to squeeze to remove the fluid from those gauze, and you can apply it. That's what we call compress. In dry wounds, you can use soaking. So you can saturate your gauze with antiseptic and put that on the wound so that the net movement of fluid is from the wound care clinics. Finally, my take-home message is, again, we need to identify the person who are at risk for the foot, because we need to prevent the development of foot ulcer. We need to educate our patients to have a proper foot care at home, and we need regularly inspect their foot during their clinic visit. We need to encourage them to wear appropriate footwear, and if there is ulcer, we need to treat. My references, you can use these references.
On this topic and on this issue. So having said that, we can directly proceed to the post-CME quiz. So the link will be posted here shortly. So we urge our attendees to attempt them all. There are a total of 4 questions. So as I've said during the introductory session, if you're able to score 50% or more, you will be issued a CME certificate with 2 CEU points. So it might take a while, so we ask that you be patient. So I'll share the link shortly. Okay, so there have been some error with the Google form. So instead, we can skip the Q&A session for today, and we'll just issue the certificate for those that have attended. So if you can just fill the survey, we will know whether you've attended or not, and we can issue out all the certificates in a timely manner. So we apologize for the inconvenience. So having said that, we can directly proceed with the Q&A. So all of the Q&As have been directly addressed by Dr. Helena. So I would like to say thank you in advance for that. But just to reiterate, perhaps to give more emphasis to the questions, I'll read them out. So the first question reads, I have a family history of type 2 diabetes. How soon and how often should I check my status? I'm 45 now. So Dr. Helena, if you could please reiterate on this.
Okay. Thank you, Dr. Fadel. So the first question so that is the current recommendation. So the second question also is directed towards me. It says, what is the availability of the mentioned drugs in our country? Those stated on the updated plans. So most of the drugs that are mentioned are not available. The only drug that is available is dapagliflozin, an SGLT2 inhibitor. So we have two and despite being overweight or obese. But the only thing that is currently being emphasized upon is that a whole body weight loss, where it targets fat loss within the liver and the pancreas. So this is very vital as to the pathogenic mechanisms of type 2 diabetes, because it's known that pancreatic fat, liver fat contributes significantly to development of beta cell damage as well as insulin resistance at the level of the liver and the pancreas. So that is what we try to target by advocating weight loss, even the non-obese individuals. Of course, those having overweight and obesity would be subjected to a greater percentage weight loss in order to achieve positive metabolic profile. So I think that would address the questions. Thank you.
So thank you very much. We have further questions. So another question reads, what do you suggest about the current popularity of ketogenic diet in glycemic control? And what evidence is to contradict the American Diabetic Association's diabetic meal?
Okay, thank you. So ketogenic diet has been proposed by several papers so far, but what is recommended by the standard guidelines and what has been also tried upon multiple landmark trials so far is a low-calorie diet. And what we mean by this low-calorie diet would be either a meal replacement in best setups, or at least minimum daily calorie restricted to 800. So that is the standard recommendation, and we don't right and left recommend ketogenic diet because of the associated metabolic adverse outcomes with regards to that. So the current guidelines recommend a low-calorie diet limited to 800 calories per day.
Okay, thank you very much. I hope your question has been addressed well. We have also another question. So the question reads, what do you recommend for patients taking insulin or sulfonylureas during fasting period and during exercise?
Okay, so thank you. That's a very important question. So recommendations, fasting recommendations for diabetic patient has its own risk stratification. So what is advised is that by fasting, we mean Ramadan fasting. So by that, those patients would be stratified in terms of their glycemic control and in terms of their comorbidities like cardiovascular established cardiovascular diseases, and also in terms of the risk of hypoglycemia, and also what type of medications that they are using. So these four major questions need to be addressed. So fasting is generally allowed in those diabetic patients who have a reasonably well hemoglobin A1C, who do not have a hypoglycemia risk, or who don't have advanced cardiovascular diseases in whom hypoglycemia could be fatal, and in those who are not on insulin or sulfonylurea treatment. So this group of patients can undergo fasting safely, and in those patients in whom we have a poorly controlled blood glucose, who have established cardiovascular disease or risk of hypoglycemia, generally fasting is not recommended, but we can't impose such recommendations. And if patients after all decide to fast, then what we need to do is at least try to adjust medications to those that have a least risk of hypoglycemia. So this does not include insulin or sulfonylureas, unfortunately. But for those in whom who can only use insulin or sulfonylurea, what we do is we avoid prandial insulins, and we reduce the basal insulin rate during the fasting season. And we try to use the longer acting sulfonylureas who have less risk of hypoglycemia. That's what we can provide. Thank you.
So thank you very much. If there's anything you'd like to add, Dr. Theodros?
So I think most of the points are well addressed by Dr. Helena. So regarding the reversal of diabetes, the most important thing currently confirmed on the direct trial is significant weight loss. So weight loss of more than 15% from the current weight can lead some patients to remission of type 2. So the most important thing regarding the different recommendation of diet is we need to restrict calorie and by any diet which can lead us to significant weight loss. Both diet, pharmacology, or bariatric surgery, some portion of patients can go to remission. The others are well addressed by Dr. Helena.
So thank you very much, Dr. Theodros.
We have one more question in the chat box from Dr. Mogas Kebaba. To what level of EGFR do you recommend SGLT2 inhibitors?
Okay. Thank you, Dr. Mogas. So the current recommendation is to use SGLT2 inhibitors in those who have GFR above 20. So that is the current recommendation as to the consensus statement by ASD and ADA.
Okay, thank you very much, Dr. Helena, for responding to the question. Okay, if you have anything to add, Dr. Rawi.
Thank you, everyone. Thank you, both presenters, for your amazing presentation. I'm sure everyone has learned a lot about care in diabetes, and also diabetic food care, which is not given as such specific emphasis in most of our routine diabetic care. For the participants, thank you for blessing us with your attendance. We'll be providing your CME certificates in a week or two time based on the email that you have registered after seeing your attendance profile from Zoom. And thank you very much.
Okay. Thank you very much, Dr. Rawi. So thank you very much, dear attendees, for attending this webinar on World Diabetes Day. So we'd also like to apologize for the inconvenience regarding the post-CME quiz. So as you've heard, we will shortly share with you the certificates based on your attendance. So the survey link is being provided as we speak. So you can fill that, and we can see how many of you have attended. The certificates can be issued accordingly. So having said that, thank you very much, Dr. Helena. Thank you very much, Dr. Theodros, as well. It was a very informative and engaging session. I'm sure everyone has learned. Learned a few things regarding this. So I can see the form link is pasted to the chat. So if you can take 5 minutes to fill it in, we'd be very grateful. Thank you.
Just to add one more point, I think the form is shared to hosts and panels, not to everyone. So maybe you can change the address to everyone on the. And the other thing, for those of you who have joined us in between, or if you want to refer to this material further, the video recording of this presentation would be uploaded to social media platforms of both the Yetenaweg and the Ethiopian Society of Internal Medicine in a couple of weeks' time. So we'll post in our groups, and you can go back and refer to the amazing lectures once more.
Thank you, Dr. So thank you very much for joining us in this webinar. I would also like to thank Dr. Helena and Dr. Theodros for their insightful session. I would also like to thank Dr. Abel for joining us here and for his cooperation during the inconvenience. So thank you very much. And with that, we will end the webinar. You can join our social media, and you can follow our accounts to see any updates about our coming webinar. So with that, our webinar has officially ended. Thank you.